I invite Dr. Mahalakshmiy for the topic, what is new in neuro-ophthalmology. Over to you.
Good morning, everyone. My topic today is what's new in neuro-ophthalmology. So we'll be dealing with the recent advances in neuro-ophthalmology. So neuro-ophthalmology has evolved in the specialty in the recent past due to the newer diagnostic and therapeutic modalities. So the clinical relevance are OCT, gene therapy, serology markers, drug molecules, teleophthalmology, and artificial intelligence in the field of neuro-ophthalmology. In IIH, idiopathic intracranial hypertension, you mainly see the recent thickness also has a positive correlation with increased intracranial pressure in IIH patients. And optic nerve head volume analysis is measured between the Brooks membrane and the internal limiting membrane by superimposing a ETDRS grid. So this is a picture of a spectral domain OCT image showing chronic papilledema with the increased RNFL thickness and GCC thinning, and there's also a clinical picture of a chronic papilledema. Other entity is pseudopapilledema, where you'll see three main entities, which is foams, which is peripapillary hyperreflective ovoid mass-like structure, which is non-specific. It's also seen in AION. And other causes of pseudopapilledema are optic disc drusen and horizontal hyperreflective lines. There's a study which shows that even if the RNFL thickness is less than 158, even without neurological signs and symptoms, it is suggestive of pseudopapilledema. But author also suggests that you do a serial OCT imaging for at least 6 months, and EDI and SSOCT is recommended for diagnosis of optic disc drusen. In case of optic atrophy, you measure, the recent advance is that you can measure along with RNFL and GCC, you also measure the minimum rim width at the Brooks membrane opening. So it differentiates glaucomatous and non-glaucomatous optic atrophy. It's measured between the ILM and the Brooks membrane. And in case of multiple sclerosis, there is overall RNFL thickness. Along with that, when you see the VEP, there is no correlation because there's a structural loss but no functional deficit present. In neuromyelitis optica, there is GCC thinning and RNFL. There's also a study showing microcystic macular edema present in 13% of patients. In Alzheimer's disease, there's decreased retinal macular and choroidal thickness. Along with that, there is in early onset Alzheimer's, you find RNFL and GCC thinning present. Gene therapy, the LHON is the most common condition where gene therapy is used, where a reflex study is done where the visual outcome of treated patients appear to be better than what is in the literature, and treating the patient 6 months before the vision loss helps better than the after outcomes. In bilateral injection of intravitreal injection given is better than the placebo, leaving it alone, and improvement in gene therapy is sustained for about 5 years. The new biomarkers in neuro-ophthalmology is aquaporin 4 antibody. It's a biomarker for NMOSD, neuromyelitis optical spectrum disorder. Bilateral optic nerve and chiasm is involved. There's posterior portion of the optic nerve is enhanced. In case of poor recovery, IVMP is crucial with plasma exchange. In case of relapse, immunotherapies are mandatory. MOG antibody is the another entity where you'll find that optic neuritis is the presenting feature with optic disc edema and pain on eye movements. MRI will show optic nerve enhancement, often extending to optic nerve sheath and periorbital fat. Corticosteroids are the early treatment for spontaneous recovery, and plasma exchange if steroids are not responding. In chronic relapsing patients, immunotherapy is suggested. Another antibody is collapsing response mediator protein, which is seen in paraneoplastic antibody. Most commonly, they are also accompanied by retinitis, vitritis, and iritis. And systemic steroid shows visual improvement. It's an overview of all the antibodies seen here. So typical features of these antibodies shown in aquaporin, MOG, and collagen protein. Here is a localization of visual pathway, where in MOG you will find that optic perineuritis is affected. In aquaporin, chiasm and tract, and multiple sclerosis, it's focal optic neuritis. Biomarker. The new drug molecules that are seen are tocilizumab, where it's seen in GCA, giant cell arteritis, and IV teprotumab for thyroid-associated orbitopathy. And in case of exenatide is the new drug that has been developed for active IAH. Telemedicine, it's been higher up before starting from COVID-19 period. But it also limits decision making in secondary opinions and triage. Artificial intelligence in neuro-ophthalmology, there's a deep learning system where they feed the images of normal and the abnormal images, and you send the patient image and they give you the they detect the underlying neurological condition. There's something called brain and optic nerve study with AI, which distinguishes papilledema accurately and identified from trivial fundus images. However, AI cannot replace human physicians, and it should remain as an assistive tool. Thank you, and these are my references.
Thank you, Dr. Mahalakshmiy, for the excellent talk on newer advances in neuro-ophthalmology.